So good afternoon to everybody. I'm Luca Iaccarino from the University of Padua. This is my last time as a disease coordinator for UCTD. I introduce my co-moderator, Cristina Pamfil, which is a disease coordinators like me for UCTD. And I'm honored to introduce the speaker, who is Patricia Carreira, from the Rheumatology Department, University Hospital 12 Octubre, from Madrid, Spain. And the topic that she will discuss with us is vaccination in undifferentiated connective tissue disease. So please, Patricia, the podium is yours.
Thank you. Thank you, Luca. I am really thankful to Professor Iaccarino for his kind introductions. And I want to also to thank the Reconnect board and the organizing of this webinar, which is the Education and Training Committee, for allowing me to be here. I don't have any conflict of interest, besides that I am really, really a fan of vaccines. I love them. So in my talk today, I will try to answer these two questions. Should we vaccinate our patients with undifferentiated connective tissue diseases? And the second one, is there any evidence that vaccine may trigger the development of autoimmunity in patients with undifferentiated connective tissue disease? And for those of you that do not have enough time to attend this meeting, this webinar, I will give you the right answers right now. And the answers are, yes, of course, we should vaccinate our patients with UCTD, and no, there is not any solid evidence that vaccines might trigger autoimmunity in our patients with UCTD. And the same is true also for healthy people. And now I will try to address these two issues and convince you about these answers. If we look at the COVID, first, I will start telling you that vaccination is one of the most effective public health interventions. As you can see in the graphic, comparing global vaccinations rate over the years, which is on the left side, this is global vaccination, and compared with children mortality in the right, you can see that while the rate of vaccination increases, the rate of mortality in children decreases. And if we look at the COVID pandemic, which is very close to us, and we follow very, very carefully, we can see that when vaccination rate increases here, the apparition of new cases, the number of patients in the UCI, and the deaths all decreases. So these are data from our world in data that combines both the European Union and the United States data. And this is not, this is not just there. It has been estimated that COVID vaccines have saved more than 20 million people lives worldwide. Only during the first year of COVID vaccination. And this is not true only for COVID. Other vaccines, which are generally used in European and or Occidental countries, as rubella, meningitis, papillomavirus, etc., have been also estimated to save thousands of lives. We all know that our patients with UCTD and other connective tissue diseases have several reasons to be at higher risk of infection. The disease itself, which comprises a kind of dysregulation of the immune system, the comorbidities that many times accompany the disease, and very especially the therapies we use for the control of the disease, as glucocorticoids, immunosuppressants, biologics, and targeted therapies, all of them associated with a higher risk of different infections. And it is well known, as shown in this study coming from Norway, which included more than 1,500 patients with connective tissue disease, that infection together with cardiovascular disease and cancer is one of the leading causes of death in every connective tissue diseases. I have to tell that there are not specific literature regarding undifferentiated connective tissue disease, and most of the information that I can bring here comes from studies from the whole group of the connective tissue diseases. So because infection is a very important cause in our diseases, most scientific societies all over the world, and of course EULAR, our society, recommend active vaccination for patients with every connective tissue disease, and also for inflammatory rheumatic diseases. Then, as recommended by EULAR and other societies, we should vaccinate all our patients with CTD. But are vaccines safe enough for our patients? In this graphic, you can see which is a vaccine life cycle. And it is very important to know that first, there is a long time for vaccine development with all the basic research and then clinical study. But after the approval, when that is review and approval, there is a very active surveillance and continuous safety monitoring by the regulatory agencies during many, many years, not just at the beginning. They continue for many years. Again, coming to COVID, this is a representation of how COVID vaccine surveillance is being organized in the world. Any adverse events will come to a, let's say, subnational level database. And then this database is submitted to a national and bigger database, and then at the national level, transmitted to the global level, and together with the data also obtained from the manufacturers of the vaccines, all this data come to relevant committees to analyze and to see if there is any safety problem with each one of the vaccines. If you visit the European Medicines Agency, if you go to the website, you can see how our regulatory agency, together with experts from all over the world, especially in Europe, try to keep all medicines and also vaccines safe for our patients. And not only for our patients, but for the general population. So with all this active surveillance during so many years and with so many experts, we can say that vaccines are really very, very safe. In this really great systematic review of the evidence about safety in vaccine science, that extensively reviewed the all adverse events which has been attributed to vaccines, they showed, as you can see in this table, these are the only adverse events that can be attributable to some vaccines. And as you can see, except for arthralgia or arthritis, which are usually mild and transient, and associated with rubella-containing vaccines, all of the other adverse events which have been analyzed are rare or very rare, being reported in less than 1 in 1 million doses of the vaccines. And for all other symptoms described or disease ever associated with vaccines, the authors found no causal relationship established between the adverse events and the vaccines that are currently recommended. And well, as we will know from the COVID pandemic, there are different types of vaccines, and all of them contain antigens that are able to elicit an immune response against the virus. But in addition, most vaccines contain adjuvants to enhance the immune response, and also other substances as stabilizer or preservatives to keep the vaccines safe. And talking about the adjuvants brings me to talk about the ASIA syndrome. ASIA is an acronym of autoimmune inflammatory syndrome induced by adjuvants, and it was described by Professor Pamfil back in 2011. ASIA encompasses not only adjuvants, but also all possible environmental immune stimulator, as infectious agents themselves, medical implants, tattoos, and many others. All these agents would be capable of triggering autoimmune symptoms in individuals who are genetically predisposed. Patients with ASIA syndrome present generally with non-specific signs and symptoms such as fatigue, myalgia, weakness, that don't really fit in any well-defined disease. These are here the proposed criteria for ASIA syndrome. They always include a history of previous exposure to an agent, and also the improvement of the symptom after the removal of this exposure. And the criteria also include the apparition of autoantibodies or antibodies directed towards the suspected adjuvant or antigen. And it has been also described a specific HLA epitope. If we look carefully to the UCTD criteria proposed by Professor Marta Mosca in 1999, ASIA syndrome share many similarities, or some of them, with undifferentiated connective tissue disease that sometimes also present with non-specific symptoms, more or less typical or other autoimmune diseases. Also, in all the cases, in the opposite of ASIA syndrome, in UCTD is always necessary the presence of serological evidence of autoimmunity. These similarities between the two diseases led to Professor Angela Tincani to analyze the relationship between exposure to different immune inducers, which are listed here in this blue box, and UCTD. In this case control study, which included 92 patients with UCTD and 90 controls, the authors found that the exposure was much more frequent in UCTD patients, and that these patients presented some symptoms typical of ASIA symptoms, especially fatigue or weakness. In this other study, an Italian group analyzed, this is a very interesting study, analyzed the vaccine adverse event reporting by the reporting system in the United States, which is one of the largest databases including adverse event following vaccination in the world. And the authors very carefully analyzed the adverse events reported after papillomavirus vaccinations, and from more than 50 million doses of vaccines, they recovered almost around 4,000 patients reporting symptoms which were compatible with HS syndrome. The main problem of this study is that it doesn't include a control group, which makes it really difficult to extract any robust conclusion, because as you can say, this group of patients are the 15% of all reported adverse events, which were less than 0.0005, which is a very really small proportion of the total patients. But in spite of those and many other reports, usually with a small number of patients, epidemiological studies do not support the concept of Asia syndrome as a consequence of vaccination. In this meta-analysis, which includes all published studies after hepatitis B vaccine, the authors conclude that there is not an increase in the incidence nor in the severity of autoimmune disease after hepatitis B vaccination. This is a very large and robust meta-analysis looking for different autoimmune diseases, not only the rheumatological, from other groups of autoimmune disease after vaccinations. And in this very large meta-analysis, they didn't find any significant associations between different vaccines and the development of autoimmunity. And when, as you can see, they looked at autoimmune disorders in many different organs, and they analyzed separately each one of these groups of diseases, and they didn't find in any of them an association, including connective tissue diseases. But as you can see here, comprises not only systemic diseases, but also inflammatory rheumatic conditions. This other meta-analysis review the risk of systemic lupus erythematosus development after different vaccines, and they include more than 45 million people without any evidence, as you can see, that lupus may appear as a consequence of vaccination. But what happened with when we vaccinate our patients? Do they flare after vaccination? This has been very well addressed, as many other things within COVID pandemic. And in this study, including more than 4,500 patients with autoimmune or inflammatory disease, flare was seen in less than 5% of patients. And flare were also usually mild and didn't require hospitalization or increase on medication, and usually they were transient. If we analyze the factors that influence or are associated with flare in these patients, in our patients, the most important of them, besides disease activity, was the reduction of cessation in the medication. So it seems that activity is the worst factors to have a disease flare, as it is logical. And for other vaccines, as influenza in this case, this is a very interesting analysis, looking at things from the other side. This is a study from Great Britain, looking at the consultations for joint symptoms or glucocorticoid prescription in primary care before and after the vaccination. And the authors we found that the joint symptoms and glucocorticoid prescription were more frequent 15 days before the vaccination than after vaccination, suggesting that influenza vaccine, which is what was looking at, is not associated with flares in rheumatic diseases. It's not a direct view, but it's indirect but very potent view. This I found this very interesting. And having all this in mind, the hesitancy for vaccination remains very high, even if there is so much science behind vaccines. And which are the top 3 reasons for this hesitancy? These are doubts about the scientific evidence, differences in cultural or social reasons for patients, and the lack of awareness about the risk of infections that are not prevented. And because of mainly these reasons and perhaps others, our patients do not want to get the appropriate vaccines. What we should do as scientists, there is probably not only this information, which is in the web, in networks, it's everywhere, the misinformation, which is usually more easy to understand from patients, so they believe this more than science. So it's only probably, it's also miscommunication from us, from their doctors. And in this regard, we as rheumatologists need to make an extra effort trying to very carefully explain to our patients why they should get vaccinated. I hope I have convinced you, this is my last slide, that vaccines are very effective, very safe, and have demonstrated that over the years, they have saved many, many lives. That there is not any really good epidemiological evidence that vaccines might trigger any autoimmune diseases. And although vaccines may induce flares in our patients, a small percentage of our CTD patients, these flares are usually mild and transient. And to conclude, my conclusion is that it is essential to vaccinate all our patients because we know they are at higher risk of infections. And many thanks to all of you who are listening. Thank you.
Thank you.
Thank you, Patricia.
So, Cristina, if you want to open the talk to the discussion.
This was an excellent talk. I guess it definitely answers many open questions that we had as physicians in our mind. There are no questions in the chat, but I would like to open the discussion and ask you, Patricia, you have an extraordinary large clinic of systemic rheumatic diseases patients. What do you personally recommend UCTD patients with regard to vaccination?
The same as to all our other patients. As you know, my hospital is a huge, very big hospital, and all of our patients, all inflammatory or systemic diseases, the very first day that they are diagnosed, even if we have not clear that these UCTD patients that come just with a little ANA positive and some arthralgia and nothing else, we send them to the preventive medicine department, and they got the things for everything which is in the calendar for immunosuppressed patients. For instance, we don't have zoster vaccination before 50 years. It's not approved in Spain. It's not financed, so we cannot use a zoster vaccine for everyone. But yes, after 50 years, if they are, especially if they are receiving immunosuppressants. But of course, I send them for vaccination for everything, pneumococcal, and they check every vaccines that the patient don't have, and they our colleagues in preventive medicine, they will do everything. They have a special vaccination unit. And I have to tell, I never saw, well, I saw some people, I think all of us saw some people after COVID, kind of arthralgia, and after vaccine, but also after the infection itself. So I don't know if this is clear. Usually not bad diseases, actually.
So basically, the point is that you don't see flares after vaccination. We shouldn't worry about this.
To me, in my experience, this is just thinking with my head. I remember perhaps 2 or 3 Sjogren's patients who has little flare active after vaccination, but no more. I don't remember really. Perhaps some people tell, "Oh, I have more arthralgia a few days," but you also have you don't have any disease, and after influenza or COVID, you have like kind of influenza, flu-like. So I am not sure if these are really flares or the same as other people have, some flu-like symptoms, nothing else. In my large experience, I can tell I didn't see, really, I try to remember, I didn't see really bad adverse events. Taking the patients to be in the hospital with really sick. I don't remember that. I don't know about you. Luca.
It's very reassuring because I know that you have more than 2,000 UCTD patient clinics, so this is highly relevant for us. And one more question, because before I give the floor to Luca, do you have the same reluctancy for live attenuated vaccines?
For what?
Do you have the same reluctancy as we have for SLE patients or other connective tissue disease patients to prescribe live attenuated vaccines?
The live attenuated vaccines is another story because live virus are much more complicated, and it depends on the treatment that you are giving to them. We usually don't give vaccines, live attenuated vaccines to our patients who are under immunosuppressants, because this is difficult. We do it very carefully in some very specific cases. If we can stop the therapy for a while, better, but still is not clear if with immunosuppressants you can use this. So they are telling that now that there is not so big problem, but I am afraid about that, especially with, of course, with rituximab. Probably we all know rituximab will be almost forbidden to give that, but for the other things we don't give to the patients the attenuated virus.
Thank you.
Can I ask a question?
Yes, please.
I have a question to you, Patricia. I agree with you that the risk of flare after vaccination among the different connective tissue diseases is extremely low, and also the Reconnect performed a study on different connective tissue diseases, including lupus. I don't remember, probably also UCTD, and they demonstrated that the rate of flare is very similar to the rate of patient out of vaccination. So So it means that vaccination does not increase the risk of flare in these patients. So this is a very important point to be underlined also for patient, also for the audience. However, I would like to ask you, if you face with a patient which is skeptical about vaccination, what do? You try to convince him or her, or in case in which way we try to convince the patient? Because I know in my clinical practice, I guess also in your clinical practice, you will face with the patient which is skeptical about vaccination, the famous no-vax patient, no-vax people. How do you deal with this?
I don't think we have many of this in Spain. You know, in Spain, the rate of vaccination after COVID was quite high. And even if we have some famous people, you know, anti-vaccine, it was not so big. Some patients still are very reluctant and they don't want to. I try to convince them with science. You know, I always tell them, I never used to vaccinate myself for a long time because I never get sick. So, and then an infectious disease colleague of mine told me, how you are not vaccinating with all the patients you have around? You know, it's so immunosuppressed. And I felt so bad. This was like 20 years ago. Since then, I get vaccination every year, and I feel so, you know, I have to do it. It's important, not just for me, it's for my patients, it's for the people around. I try to explain things like that, trying to tell, you know, to show from all the thousands of millions of doses over the world, just a few patients, it is true, they can have some harms. Of course, any medications can do some harm, but it's very, very small. And you put in a weight, which is better or not. I try to explain this. I try to be convincing, but sometimes you cannot put anything. That's it, you know. Sometimes I have patients who don't get the vaccination, but all their relatives do, you know, to care from the patients. It's difficult when, you know, this is established, you know, in the web, and it's very difficult to, but I try to explain, you know, to say all this data, so many doses of vaccines, and everybody knows because vaccination for COVID was on TV all the time. So everybody saw that, so many people getting vaccines. And so I try to do it, but sometimes you are not going to convince the patients. You can do nothing. It's not mandatory. So
I have another question. How do you deal with you correctly, in my opinion, told us that especially immunosuppressed patients should be vaccinated. But how do you deal when the patient is under immunosuppressant and he or her need to be vaccinated? Do you withdraw, suspend, temporarily discontinue the vaccination, or you continue on the vaccination and you vaccinate the patient?
We continue to vaccinate the patients. The only exception is rituximab. We try to put the vaccine right after 6 months and then prolong a little longer. And we do this trying to avoid the problem with rituximab. Probably after the patient has been in rituximab for many years, this is not so effective, but we try to increase the effectivity of that vaccines with rituximab. For the other things, for a while, with the COVID vaccine, we stop the medication for 1 week or 2 weeks, especially methotrexate or leflunomide or things like that. But we don't do this anymore. Actually, you know, perhaps we say, some patients say, "Oh, I stopped the methotrexate for this week." Sometimes they do that by themselves, but we don't do that anymore. It doesn't seem that it's very important for the effect of vaccine. You know, everybody says it's much better to vaccinate your patients without any medication. It will be much better. But when you see them in the hospital because they come, you cannot wait most of the times because the patient is not doing well. You're going to wait 1 more month, probably when the patient has been several months complaining, going to one doctor, to another, waiting for your visit, and tell them you have to wait another couple of months because we are going to vaccinate you. So we send them to this unit of vaccination at the Department of Preventive Medicine, and we start treatment. We don't wait, of course, for the more severe patients, but still for the less severe patients, we do this, except for rituximab.
There is a question from Emanuele Gotelli in the chat. Excellent talk. Professor Carreira, do you also refer UCTD, CTDs patients, family members, and cohabitants to your preventive medicine service?
Well, it should be done. We actually don't do that so often. I think we should do that. I was talking with the chief of the department in preventive medicine about that last week, because which is true that all cohabitants or relatives who are in close contact with the patient should be vaccinated also. But this is extremely difficult, because we said these children and grandchildren who come to visit on Sunday afternoon to have dinner together, which is very often in Mediterranean countries, is very often that all the people come to Mama on Sunday to have dinner. So should we vaccinate this? Probably yes. We don't do it so closely. We do from the people who live together, like the husband or wife and some son or daughter living in the same house. But perhaps we should be more hard in doing this. I agree with Emanuele. Thank you for this question, which is very important. But things get more complicated. If you have problems to vaccine your patient, then to the others is still more difficult. So.
And another question refers to children. If on top of the normal vaccination schedule, in children with, let's say, lupus or other CTDs, do you recommend additional vaccines? Let's say regular anti-hemophilus or let's say anti-pneumococcal vaccine.
We have pneumococcal for all our patients. First one, I think, one of the first ones. But I didn't understand very well the question.
So on top of the normal routine vaccines for children, in children which have CTDs, do you recommend additional vaccination, such as?
We also send the children to this, and I think I'm not absolutely sure that what they get now, but I am sure they got Hemophilus and pneumococcus for sure. I am not sure about others, but for the children, the same. And the pediatrician in our hospital are very good at that, being very careful. They do it very, very well.
There are at the moment no other questions in the chat.
I think, Cristina, we can close. We can thank Patricia. What do you think?
Yes, indeed, it's been a wonderful webinar with a wonderful talk from Patricia, and we're grateful for this.
Thank you very much to all of you.
Thank you, Patricia, and thank you all the audience for listening this talk. And see you to the next webinar. So, bye-bye.
Bye-bye.
Have a nice evening, everyone. Bye-bye.
You too. Bye-bye.